Bem-vindos ao webinar de lançamento do 44º Congresso Brasileiro de Angiologia e Cirurgia Vascular, o maior evento oficial da nossa Sociedade Brasileira de Cirurgia Vascular. Eu gostaria de agradecer a todos os associados e a todos da América Latina, em especial os nossos convidados da Argentina, do Peru, da Colômbia, da Bolívia e de todos os países latinos que nós convidamos para agregar nesse lançamento do nosso congresso. Gostaria de agradecer imensamente, em nome da sociedade, o professor Samuel, Dr. Eduardo Ramacciotti e Dr. Fabrício Santiago, que vai fazer essa mediação. Eu gostaria de aproveitar essa oportunidade para dizer que o nosso congresso do ano que vem está sendo planejado para ser presencial, para ser o grande reencontro, né? Nós estamos passando os tempos difíceis, mas a nossa intenção, todo o nosso planejamento é de fazer um grande reencontro da sociedade brasileira e dos nossos amigos vizinhos, né, que possam, porventura, participar conosco aqui em Brasília. O congresso acontecerá em outubro do ano que vem, do dia 12 ao dia 15 de outubro de 2021, no Centro de Convenções Ulisses Guimarães, aqui em Brasília. Toda a programação está sendo trabalhada com muito carinho, nós não queremos fazer mais dos mesmos, queremos fazer algo de interação, de troca de experiência, né, nessa privação que tivemos aí desse ano, para tentar compensar isso. Então, gostaria então de dar início, dar a palavra para o Dr. Bruno Naves, presidente da Sociedade Brasileira de Cirurgia Vascular, nosso presidente, e em seguida, Dr. Leonardo, presidente da nossa regional.
Boa noite a todos. É uma grande alegria poder estar dando esse pontapé inicial ao Congresso Brasileiro de Angiologia e Cirurgia Vascular, o principal evento da sociedade brasileira. Eu gostaria de convidar a todos os senhores. O Congresso está sendo preparado com muito cuidado, com muita emoção, com muito carinho, porque, como bem disse o Antônio Carlos, será o nosso momento de reencontro. Olhos nos olhos, a gente vai voltar a se ver, a interagir. Se Deus quiser, vai ser um excelente evento. O conteúdo científico está muito bom, muito bom. Então, assim, eu faço um convite especial. Já reservem para o ano que vem esse congresso brasileiro, que vai ser um congresso diferente, um congresso atraente, um congresso que, em todos os sentidos, ele está sendo bem pensado, em todos os sentidos, na sua segurança, na segurança dos palestrantes, nas informações, nas relações interpessoais, enfim, vai ser um novo evento dentro do que será considerado um novo normal. Muito obrigado pela oportunidade, desejo um excelente evento essa noite. Eu fiquei muito feliz de rever o Dr. Samuel. Nós nos encontramos a primeira vez em Barcelona, no lançamento dos DOACs, no caso, no lançamento da Rivarox Sabana. De lá para cá, eu venho seguindo a vida dele. Ele é uma personalidade incrível, um homem de um conhecimento absurdo e de uma simplicidade maravilhosa, que combina bem com as pessoas, as grandes pessoas, os grandes cientistas. Então, eu tenho absoluta certeza que essa será uma grande noite. Obrigado e bom evento.
Leonardo.
Boa noite a todos. Eu gostaria de, em nome da Sociedade Brasileira de Angiologia e Cirurgia Vascular Regional do Distrito Federal, agradecer a todos que estão aqui, especialmente ao Dr. Goldhaber e aos doutores Fabrício e Eduardo Ramacciotti, que são embaixadores do Congresso Brasileiro na noite de hoje. Eu não posso deixar de agradecer imensamente o apoio que a Bayer nos deu, um parceiro de primeira hora, né, especialmente a Ana Rivera, a Camila Matsumoto, a Elias Zanata, a Cibele, que me visita aqui, é uma pessoa simpática que nós gostamos muito da convivência com ela. Eu agradeço demais por essa organização e agradeço especialmente também a todos aqueles que estão nos assistindo e aos nossos irmãos da América Latina. Esse congresso que nós estamos preparando é para vocês também. Vocês sintam-se à vontade, sintam-se em casa aqui conosco. Vai ser um prazer enorme. Muito obrigado e boa noite a todos.
Fabrício, poder nos orientar?
Boa noite, pessoal. Eu vou falar em inglês com respeito ao professor Samuel Goldhaber. Hello, everybody. I'm going to give you some guidance. We'll have, at the end of this session, some question and answers. As you can see in the bottom right of your screen, you can see a Q&A chat, so you can make your questions, and I'm going to translate the questions for Professor Dr. Samuel. It doesn't matter if it's in Portuguese or in Spanish. We're going to select, so you have to give your likes to the questions so that I can select the best questions so that I can reply to Professor Samuel. So you have in the bottom right of your screen, you can make the simultaneous translation by clicking in the globe. You have some options for translation for Portuguese and for Spanish. So now I'm going to give the mic to Dr. Eduardo. Eduardo?
I don't have much to talk rather than thanking my colleagues from Distrito Federal for inviting us to be ambassador of our Brazilian Society of Vascular Surgery. Sam, I believe we are the second Society of Vascular Surgery in the world. We're very close to the American one in terms of numbers. We don't have much associates, but we have around 11,000 people practicing vascular surgery in the country, 210 million inhabitants here in Brazil. So we're very happy to have you here and to introduce Professor Sam Goldhaber. It is easy for me, we're very close friends. He is Associate Professor of Cardiology at Brigham and Women's Hospital at Harvard Medical School. He's the super boss, but he's so kind. And he asked me to introduce him as just an associate professor, but he's a super mega star. We like him very much. He participated in the majority of really important trials that guides us in terms of guidelines, global guidelines. And Sam has very interesting views in V2E treatment extension that he's going to share with us. And at the end of his presentation, both me and Fabrício will help answering questions that will come out of the Q&A and some questions ourselves have for Sam. So Sam, the stage is yours.
Thank you, Eduardo. I am very humbled and feel very privileged to be leading off this 44th Congress of Brazilian Vascular Surgery and Angiology. We feel very close to Brazil. We have many ties within cardiovascular medicine and vascular medicine. And I want to also thank Bayer for their extraordinary grace and excellent organization of this conference. And I too hope that 1 year from now, we will all be vaccinated and able to socialize together in person rather than virtually. This evening, I'm going to talk about venous thromboembolism anticoagulation, and there's been a controversy between whether we should use an end date for anticoagulation, like 3 months or 6 months of anticoagulation, versus extended duration therapy without an end date. Here are my disclosures. And I'll speak about epidemiology, pathophysiology, the idea that pulmonary embolism has very close links to myocardial infarction, stroke, and heart failure. I'll discuss the optimal duration of anticoagulation, but using the new guidelines from the European Society of Cardiology, which instruct us to stop trying to categorize pulmonary embolism as provoked or unprovoked. Now, in the United States, unfortunately, the age-adjusted mortality was decreasing until about 2011. And especially the past few years, the age-adjusted mortality is increasing. This is the wrong direction. And it turns out that the socioeconomically disadvantaged have the biggest price to pay. There is a lot of health inequity. The decline in life expectancy is greater among individuals with limited education and income. And unfortunately, the gradient in life expectancy based on income has widened over time. For example, back in year 2000, the median age of death from pulmonary embolism in the United States was 73. But now, 2017, the median age of death from pulmonary embolism in the United States is 68. All-cause mortality and pulmonary embolism mortality are increasing in the United States, but decreasing in Canada and Europe. Here we see Canadians in red and Americans in blue. Both the American women and the American men have a higher pulmonary embolism death rate than the Canadian women and the Canadian men. Furthermore, again, since year 2011, we actually see an increase in pulmonary embolism death among American men and a continued decrease in pulmonary embolism death among Canadian men. And this is what we all fear. This is a massive pulmonary embolism. This couldn't actually embolize into the pulmonary artery. It was too large. This thrombus was found in the right ventricle. And this yellow square has inside it, if you look very carefully, an imprint of one of those delicate venous valves of the legs. Now, in terms of pathophysiology, we have in the past thought of the pulmonary embolism as a red clot disease and myocardial infarction and stroke as white clot diseases because of all the white blood cells and the platelets. And here we see a regular trichrome stain of a patient who died of massive pulmonary embolism. And in this micrograph, everything is red. And we're thinking to ourselves, these are red blood cells clumped together because pulmonary embolism is a red clot disease. However, with special staining, all this brown area represents polymorphonuclear leukocytes, white blood cells, the polys that are rushing in to this inflamed tissue, the thrombus of the pulmonary embolism. And the blue staining these are activated platelets ready to burst with thrombogenic sequences that will cause more thrombosis. So really, the pulmonary embolism is not only a red clot disease, but a white clot disease. It's filled with white blood cells and platelets, and it's very inflammatory. Here, we see that these green mitochondria, they're secreted from these activated platelets. And these mitochondria promote increased inflammation. And here, under electron microscopy, we see fibrin strands. These would be the target for anticoagulants. And these are the activated platelets. These would be targets for anti-inflammatory therapy. Now, this understanding of the link between inflammation and pulmonary embolism leads to a host of risk factors for pulmonary embolism that are really inflammation-linked conditions that can trigger pulmonary embolism or deep vein thrombosis. They include ulcerative colitis or Crohn's disease, rheumatoid arthritis or psoriasis, an elevated LDL cholesterol or elevated lipoprotein a, obesity or metabolic syndrome, acute coronary syndrome or stroke, pneumonia or chronic obstructive pulmonary disease, and cigarette smoking. So we see that there is a lot in common between venous thrombosis and atherothrombosis. They share the same risk factors: obesity, hypertension, tobacco use, dyslipidemia, diabetes, a poor diet, increased stress of life, and estrogen therapy. And they share a common pathophysiology of inflammation, hypercoagulability, and endothelial injury. So at this point, the pathophysiology can lead to venous thrombosis, or it can lead to atherothrombosis with myocardial infarction or stroke. But if you get atherothrombosis with myocardial infarction or stroke during your lifetime, you're twice as likely than average to suffer pulmonary embolism or DVT. And if you have a pulmonary embolism or DVT during the rest of your lifetime, you're twice as likely as average to suffer myocardial infarction or stroke. Here we see a large Scandinavian study of almost 17,000 patients with pulmonary embolism with more than 65,000 controls. And these are patients who suffered acute pulmonary embolism. The first year after the acute pulmonary embolism, these patients are 2.5 to 3 times more likely than the controls to suffer myocardial infarction or stroke. But let's go out even 20 years after the acute pulmonary embolism. These patients with pulmonary embolism, even 20 years later, are 30% more likely to suffer myocardial infarction or stroke than the controls. Here we have data from the TIMI study group. In the large TIMI trials, Two of the trials were put together with more than 47,000 patients with arterial vascular disease, and the number of symptomatic vascular territories is plotted here along the x-axis. A vascular territory might be the coronary territory, the carotid artery territory, and the leg artery territory. And the more vascular territories affected, arterial territories, the higher the rate of venous thromboembolism. It's almost a dose-response curve. Even heart failure is linked to incident venous thromboembolism. Both heart failure with preserved ejection fraction and heart failure with reduced ejection fraction. Both types of heart failure have hypercoagulability in endothelial injury. Heart failure with preserved ejection fraction also has left ventricular stiffness and decreased myocardial compliance. And the heart failure with reduced ejection fraction has stasis and release of tissue factor. So heart failure is closely linked to pulmonary embolism, or DVT. So from a vascular medicine perspective, and I would think from a vascular surgical perspective, we don't really see these four diseases as separate entities. We see them overlapping: pulmonary embolism, myocardial infarction, stroke, and heart failure, with inflammation as a common underlying process. Let's talk about the Jupiter study of 18,000 patients who were clinically healthy. To be enrolled in Jupiter, they had to have a high sensitivity C-reactive protein that was on the high side, 2.0 or greater. And then they were randomized either to rosuvastatin, 20 milligrams a day, or placebo. And you can see that after 4 years of follow-up, the rosuvastatin group had a 43% reduction in symptomatic pulmonary embolism, or DVT. So now, with this understanding of the pathophysiology, let's return to the question of the optimal duration of anticoagulation to prevent recurrent VTE, and let us be prepared for a requiem to the idea of taking each patient and trying to categorize that patient as having either provoked or unprovoked venous thromboembolism. I'm going to quote from the ESC pulmonary embolism guidelines. Terminology such as provoked versus unprovoked PE or VTE is no longer supported by the guidelines, as it is potentially misleading and not helpful for decision-making regarding the duration of anticoagulation. The guidelines continue: extended oral anticoagulation of indefinite duration should be considered for patients with a first episode of pulmonary embolism and no identifiable risk factor, or provoked by a persistent risk factor, or provoked by a minor transient or reversible risk factor. Let's take this Danish study of patients diagnosed with VTE. And during the first 6 months of anticoagulation, let's look at the recurrence rate of a second DVT or pulmonary embolism. You see these red and black lines are superimposable. The red line is provoked VTE. The black line is unprovoked VTE. They're the same, no difference. The patients with cancer-related VTE, of course, they have a higher likelihood of having recurrent VTE. Let's look at the Framingham Heart Study. Framingham is about 50 kilometers west of Boston, where I am now at Brigham and Women's Hospital. And there's 15-year follow-up of nearly 10,000 patients with VTE. Event-free survival is exactly the same for patients with unprovoked or provoked VTE. Only the cancer-related VTE had a marked decrease in event-free survival compared to unprovoked or provoked VTE. And here is the molecular structure of rivaroxaban. The Einstein choice trial is very important because it's the first large randomized trial where the majority of patients, 60%, were entered into the trial with provoked VTE and 40% with unprovoked VTE. Patients could enroll in this trial if they had confirmed VTE and had completed 6 to 12 months of anticoagulation. So more than 3,300 patients were randomized either to rivaroxaban 20 milligrams a day, rivaroxaban 10 milligrams a day, or low-dose aspirin, and they were followed for 12 months, both for recurrent VTE and for major bleeding complications. Here we see the rationales for the 20 milligram dose of rivaroxaban, the 10 milligram dose of rivaroxaban, and the rationale for low-dose aspirin. There was no placebo group. And here we see the results in terms of recurrent VTE, markedly reduced with rivaroxaban 20 milligrams or rivaroxaban 10 milligrams a day. The dose made no difference. 70% fewer recurrences with either of these two doses of rivaroxaban compared with prescription of low-dose aspirin. And in terms of major bleeding complications, this was less than 0.5%, and there was no difference statistically between bleeding complications with rivaroxaban in either dose or with low-dose aspirin. Now, taking a deeper dive into the Einstein choice study, certain provoked risk factors in particular predisposed to a high rate of recurrent VTE. And these included heart failure, obesity, chronic kidney disease, a family history of VTE, hereditary thrombophilia, and immobility. So here is a revised strategy to determine the optimal duration of anticoagulation. And this was an On My Mind editorial where the first author was Ida Albertson from Denmark, whose work I just showed you. We feel and she worked in our thrombosis research group, that unprovoked and provoked VTE should go into the same funnel. And that as the risk of recurrence increases, the duration of anticoagulation should also increase. So now we think of the risk of recurrence based on the new ESC guidelines as low, intermediate, or high. A low risk of recurrence, this is after stopping anticoagulation, less than 3% recurrences per year. This is likely to be the case with major surgery or major trauma. And for these conditions, it's okay to have an end date for the duration of anticoagulation. The largest category is having an intermediate risk of recurrence, varying from 3% to 8% per year. These patients might have minor surgery or be hospitalized with an acute medical illness such as pneumonia, and COPD, or heart failure. It might be related to pregnancy or postmenopausal estrogens, or to a long-haul flight. Perhaps it's inflammatory bowel disease like ulcerative colitis or an autoimmune disease. And patients who have no identifiable risk factor or the unprovoked VTE, they still fall in this intermediate category. The intermediate risk of suffering recurrent VTE after stopping anticoagulation. The high-risk patients with more than 8% risk of recurrence per year after stopping anticoagulation, these would be patients who have active cancer in VTE or a severe case of the antiphospholipid syndrome plus VTE. So now for my conclusions, and I'm very much looking forward to discussion and your thoughts, your input, your questions. First, the age-adjusted overall mortality rate and the pulmonary embolism mortality rate in the United States, they're increasing. Second, pulmonary embolism confers an increased risk of myocardial infarction and stroke. And myocardial infarction and stroke confer an increased risk of pulmonary embolism. Provoked VTE predisposes to almost as much recurrence as unprovoked VTE after discontinuation of anticoagulation. And finally, we should consider extended duration anticoagulation in most VTE patients rather than a fixed stop date.
Thank you, Sam. Thank you very much. Very clear presentation. Fabricio.
Yes, so once we do not have a Q&A right now, so I'm going to keep the silly questions for you, Professor, and the hard questions for Dr. Eduardo, okay?
I like that.
What do you think about the use of D-dimer when considering to extend or not, or even stop the anticoagulation or not? Because D-dimer nowadays, it's something with COVID, it's exploding the use of it. And so what do you think about?
Well, I used to use the D-dimer when it was first published in the New England Journal of Medicine by an Italian group. And I would, in those days, if it was a normal D-dimer level, I would call up the patient and say, congratulations, your D-dimer is normal. You can stop anticoagulation now. And I had many phone calls with patients like that. And often 1 or 2 years later, they'd come back into the hospital with a recurrent large DVT or pulmonary embolism. In my hands, it was totally unreliable. Then the McMaster group from Hamilton, Ontario, with the late Clive Kieran, also did their own study, and they found that there was at least a 5 to 10% rate of the D-dimer being normal with a recurrence within the next year or two. So that's too high, that our patients won't accept that level of failure. So I don't think it's useful for COVID now. That's a different situation. The D-dimer is useful for COVID because the D-dimer is sort of a global test of hypercoagulability. And we're seeing often in the sickest patients, those who go into the intensive care unit with COVID who require mechanical ventilation, the D-dimer level is often greater than our laboratory assay can measure, 4,000, 10,000. And these patients have a poor prognosis. So this can be used as a way to prognosticate the patient or even to triage the patient to an ICU or a step-down unit within the hospital. The D-dimer has its best use, I think, for the diagnosis or rejection of the diagnosis of pulmonary embolism in patients who otherwise are at low risk of having a DVT or pulmonary embolism. I wouldn't use it for DVT, but for pulmonary embolism, the story really does not sound convincing. They have a normal D-dimer. You can send these patients home without any CT scanning. There has been now a very important finding with the D-dimer. We used to say the upper limit of normal is 500 nanograms per ml. Now we know that as we age, the upper limit of normal rises. So a 70-year-old, 700 nanograms per ml would be normal. A 90-year-old, and we have more and more 90-year-olds in our practices, even both men and women, that would be 900. And if you use the age-adjusted D-dimer, you can cut down in the patients 50 years of age and older the frequency of CT scanning by about 30 or 35%.
Okay, thank you very much. And my last question, and I'm going to pass the mic to Dr. Eduardo. I know that we're recently considering the replacement of provoked and unprovoked by transient and non-transient risk factors, but I'm going to use provoked and unprovoked. So we have some colleagues that we are not familiarized with that. So would you consider extending anticoagulation in patients with distal DVT with unprovoked factors?
Well, this is a very tough question. First of all, distal DVT in the calves. Now what's happened, without necessarily definitive evidence, all around the world, these patients are receiving extended anticoagulation, and they're being treated like patients with femoral vein DVT. So that's just happened, and we have to deal with that. I think when I evaluate a patient to decide the optimal duration of anticoagulation in a patient where the initial DVT might not be that serious. I also looked at a lot of other factors to see if we should give an end date to anticoagulation, like 6 months, for instance. And if you look at a study we published from the Garfield VTE registry, even at a year, half of these patients were on continued anticoagulation. But what am I looking for? I'm looking for a low LDL cholesterol level. I'm looking for a body mass index between 20 and 25. I'm looking for 6 days a week of some exercise, which could even just be walking. I'm looking for no cigarette smoking. And I think the DVT, these patients with the DVT in the calf, they have a higher mortality rate, not because of the DVT, but because that distal DVT is serving as a surrogate and is telling us there's a lot more wrong with this patient from a cardiovascular system than just the DVT.
Okay, thank you very much. And thanks a lot for your input about the relationship of PE and MI, stroke. It was outstanding. So Eduardo, I'm going to pass the mic to you. We have one Q&A. After your considerations, I'm going to make the question, okay?
Okay. So Sam, very nice presentation as usual. A very practical question for our vascular colleagues here. As you are aware of, vascular surgeons do handle a lot clinical medical management of venous thromboembolism here, differently from the US. So help my colleagues understanding which dose to pick in extensions, 10 versus 20, including the number needed to treat and the real benefit, and what to do with cancer patients, given the fact that our trials did not evaluate an extension with a reduced dose.
Okay, well, to start with the cancer trials, these patients are extremely hypercoagulable. They need, if we're going to use a DOAC instead of low molecular weight heparin, we really have to give full dose. And I think giving half dose in most instances, unless the patient is very frail or has renal failure, it's likely to lead to a recurrent DVT or pulmonary embolism. So I would stick with the full dose for those patients. And I'm not sure I understood the first part of your question, Eduardo.
From a practical standpoint, you have a patient, he completed 6 months of treatment, he has no cancer, and now you have the option to decrease the dose or to keep it as 20. What is the practical rule for this distinction, Sam?
What we do is we follow the Einstein choice trial, and if the patient's doing well clinically, we cut the dose in half to 10 milligrams a day from 20, and we tell the patients that on 10 milligrams a day, your bleeding risk for major bleeding complication is about the same as low-dose aspirin.
Okay, and another question that is a burning question here, and it doesn't deal with VTE treatment, but it deals with extensions. We are close to have the approval here for extensions for VTE prophylaxis in the medically ill population. What's your take on extending prophylaxis and your take on the D-dimer in this very particular population?
Well, a lot of the trials use the D-dimer so that we can get a higher risk group to study. But I don't think you need to use the D-dimer in practice. The problem has been, Eduardo, that so far nowhere in the world has the medical community bought into the concept of extended duration prophylaxis, even though whether it's with rivaroxaban or betrixaban before it, this hasn't been utilized. And I think that this society is a very good place to start to try to change that paradigm, because the evidence favoring 5 weeks of anticoagulation with rivaroxaban in the reduced dose of 10 milligrams a day is quite compelling. Not only does it reduce the rate of recurring VTE, but much more importantly, it reduces major adverse cardiovascular events. By that I mean myocardial infarction, stroke, and cardiovascular death. So, like we were talking before, the DVT, if it occurs, it's just a marker. It's a marker like the D dimer for hypercoagulability, and we have overwhelming evidence that prophylactic levels of anticoagulation really do work for that really high risk group after they leave the hospital. This is the last frontier, really, of VTE prophylaxis. And we have been unable to move the needle, but I hope that Brazil will be the first country to move the needle.
Well, we're happy with that, Sam. I enrolled a lot of patients on the Mariner trial. I've been pushing Bayer local to apply for that indication. And we're replicating Mariner for COVID patients here with a little more flexibility, and we're doing some surrogate CT scans. But I'm very happy with your question. I think you have clarified us a lot, and I believe it's time to open for Q&A we have almost 200 attendants tonight, Sam. A lot of people. It is a lot of people for a Monday night. So, Fabricio, do we have any questions on the Q&A? People are a little bit shy.
Yes, Dr. Ricardo Moraes are asking, must we use the scores or can we use medical experience to initiate or extend anticoagulation for medical ill patients?
For medical extension, after discharge for pneumonia or heart failure? Is that
probably yes, because he's asking about probably yes.
No, you can use clinical experience. You don't have to use scores. The FDA approved this extension without requiring the use of any scores.
Okay. So Dr. Almiro Vieira is asking, is there any space actually to use aspirin in the extension? What should we prescribe to patients using aspirin chronically?
Good question.
Yeah, great question. I think for orthopedic surgical prophylaxis, there are observational data that 81 milligrams of aspirin twice a day can be quite effective in prophylaxis against VTE and joint replacement therapy, but so can rivaroxaban 10 milligrams a day. And in fact, rivaroxaban 10 milligrams a day is more effective than 40 milligrams of plexane once a day. So I think we have many choices. Our patients who have coronary stents really must be kept on either aspirin or clopidogrel indefinitely. We're not fans of dual antiplatelet therapy anymore, except for the first few months after implantation of the stent. But I think that for patients with serious coronary disease, particularly those who've had stents put in or who've undergone coronary bypass grafting, we have to use aspirin or clopidogrel. And then, in addition, we would use the anticoagulation to treat pulmonary embolism with DVT.
Okay, let me see here, another question. Okay, if there is a patient with distal DVT after 2 months of, after COVID-19, patient with DVT, distal DVT after 2 months of having COVID-19 diagnostic. Would you consider provoked or non-provoked DVT, anticoagulate for 3 months or more? What do you think about?
Well, so that falls into the intermediate category in the European guidelines, the ESC guidelines, because these patients almost always present to the hospital with COVID pneumonia. So this is like other pneumonias where there's really striking evidence that patients discharged with pneumonia, medical patients do much better with low-dose anticoagulation for 5 weeks. We don't know the optimal duration of anticoagulation in COVID patients, and I think based on a study we published in the Journal of the American College of Cardiology on November 3, which was 6 days ago, our experience with 1,100 COVID patients, it very much depends how sick the COVID patient was, whether the COVID patient went to intensive care or a step-down unit or was going to be treated completely at home. Now we're in a very, just to digress for a moment, we're in a very strange state in the United States. We had 4 days in a row of more COVID cases than ever before, 4 straight days in a row. Yet our mortality rate is not nearly as high as it was back in the spring of this year. We think that's because the average age and the median age of the COVID patients now across the US is less than 40 years of age, and they're better able to recover.
Okay, what about unusual sites of thrombosis? I mean, splenic vein, portal veins, or what about extending the anticoagulation? What do you think about? A question from Dr. Lucimelli.
Yeah, another tough question. We don't have trials to base our decision. And then a lot of us will use repeat CT scans. And if the thrombus is still there, we'll continue to treat. And if the thrombus is not there, we'll declare victory and stop anticoagulation. The problem with that approach is that the thrombus that's still there may be totally biologically inactive. And for the patient who has no evident thrombus on the CT scan, that patient may biologically be very highly predisposed to another thrombus. So we really don't know what the best course of action is there.
Okay, Dr. Leonardo, he's going to ask you a question, and then I have one last question that I had to select here with the light so that we can pass the mic to Dr. Eduardo. Leonardo?
Thank you, Fabrício. First of all, congratulations, Dr. Samuel, for your brilliant and outdated presentation.
Thank you.
Professor, in patients with COVID-19 and DVT, which one do you prefer to treat with low molecular weight heparin, and which one do you feel more comfortable to treat with DOACs?
So, great question. I think it depends where the patient is hospitalized. There are really 3 categories of patients: hospitalized in intensive care, hospitalized in a step-down unit, or quarantined at home. For the intensive care patients, these are the ones who are most likely to die, we would always use low molecular weight heparin. We would not use DOAC because these are critically ill patients. We don't really know how much anticoagulation they are receiving with the DOAC, and at least in our units, 80% of these patients are on mechanical ventilation. So in the units, we would give low molecular weight heparin. Usually, though we don't have any randomized trials to prove it yet, usually we'd give double. We'd give Clexane 40 milligrams twice a day rather than once a day, because in our early experience last spring, we were having everybody breaking through with thrombosis on Clexane 40 milligrams a day. So we doubled it. Now in the step-down unit, the question is a great one. Can we switch the patient to a DOAC? And I think the answer is we really don't know. There are ongoing studies of this, and we should get an answer probably within the next year or two. But I think from everything that we know about DOACs, they should be effective in these patients, both for prophylaxis or for therapy if there's breakthrough thrombosis. Finally, there's the patient, and this is now the most common scenario we have. The patients, the vast majority now, who are sent home in quarantine. They never are hospitalized. There, we are doing a randomized controlled trial with rivaroxaban versus placebo, and what we're doing for the endpoint to see what percent of these patients develop arterial or venous thrombosis in these patients. It's one of these trials that's contactless. So we never meet the patient in person, face to face. We have virtual conversations with them. I'm sure you must have services that drop the food from the restaurant at your door, ring the doorbell, and then go away quickly. Well, we do this. We actually, there are now businesses that will do this, and they'll deliver to the door of the patient the rivaroxaban or its placebo contactless. So we'll say study medication, they ring the doorbell, they are off. Also, we obtain the informed consent, written informed consent, contactless as well. So we're depending on the electronics, but we'll have an answer to whether we should be giving rivaroxaban prophylaxis, in this lower risk population over time. And it's important because now, at least for us, the population that is being stricken is the young people, the people under 40. In Boston, it's particularly problematic because we're a big student town with many universities, and so there are students in fairly close quarters, and they like to party, and so the rates of COVID are very high. And you may have heard that we have one of the biggest holidays that we have, and my favorite holiday is Thanksgiving with the turkey. And it's really a family holiday. It's no buying presents, it's just being with your family and watching American football and eating eating a 5,000 calorie dinner. We're having a big controversy about whether the students stay in the university or whether they go home, because now many states have rules. They don't have. They used to even have border patrols between the states that say, okay, you're coming back from Florida to Massachusetts, you're going directly to your home, you're staying there 14 days. So there's this whole issue of quarantine.
Okay, I have one last question, and I'm going to pass the mic to Dr. Eduardo. So I don't know if I can translate it because probably there are some problems with the timeline for the question. In a young patient without ovaries, probably a tumor, I don't know, I cannot tell, that have presented with pulmonary embolism, and they need probably hormones after having their ovaries removed. What do you think about giving back the hormones and keeping the anticoagulation, or what do you think about that?
Yeah, I think it's a good idea because they need the hormones to live a normal life. And we do this, and it's a successful strategy by and large. Now with the DOACs, it's much easier than in the old days where we had no choice and we were forced to use warfarin or low molecular weight heparin. So,
okay, but how about the time to extend the anticoagulation?
Well, I think the anticoagulation should be extended as long as they're on hormones that provoke VTE. And that could be testosterone as well as estrogen.
Okay, thank you. Eduardo?
So, Sam, thank you so much. We're hitting the time, but I was informed we have a little bit of flexibility, some final minutes. And my very short question for you, and I need a short answer. As you can see, we were bombed with questions regarding aspirin, anticoagulation, dose. And these questions, they repeat and repeat and repeat throughout the years. And we made an exercise with some Harvard folks, and you know who I'm talking about. And we calculated that given the number of oral anticoagulants plus number of heparins plus the number of antiplatelet agents, we have 2.8 million permutations in terms of what can give to our patients. So my question for you, Sam, how do we educate our folks? They are on the front line taking care of really sick people. They are on the ICU, on the OR, seeing trauma patients. We have a very violent country here. What do scientists, what should we do to better educate our colleagues and to facilitate how they proper prescribe anticoagulations and antiplatelets from your perspective?
Well, I think education is the key. And, societies like this great vascular surgery and angiology society are where the educational leaders come to learn and then go back and become champions at their hospitals of the best practices. It's often helpful to have guidelines that are hospital specific. This might depend upon what antiplatelet agents or what anticoagulants are available in the hospital formulary. And then it might depend on what the transition of care is like from the hospital to after hospital discharge.
Thank you so much, Sam. Fabricio, it's 7:08. In respect to Dr. Sam and to the audience, I think we should finish the meeting.
This has been a great pleasure.
Sam, you're becoming Brazilian, you know.
Yeah.
And this is a vascular meeting. If we have invited the cardiologist, you have a fan club here.
Yeah. Well, I hope we all get vaccinated over the next 6 or 8 months, and then we will have this meeting like this over dinner.
Absolutely. Absolutely.
And
Sam,
Professor,
on behalf
Professor,
of our society,
okay, Professor, I was informed that you're going to be officially invited to our meeting.
Oh,
So you're probably are going to receive an invitation letter officially, so that we can be with us personally. Okay, Eduardo, I'm sorry. You can.
I can hardly wait. Thank you.
and I can talk on behalf of my colleagues, Bruno, Antonio, Leonardo, who are in charge of our society and from the meeting. And we can thank you more for this very nice jumpstart.
Yeah, well, it's been
our meeting.
It's been a great discussion, and I'm sure the rest of the days of the meeting will be very engaging, and everyone will have a chance to get intellectual stimulation and great discussion.
Bruno, Antonio, Leonardo, anything else?
Não. Fantástico.
No, that's okay.
Eu gostaria só de falar uma coisa importante, que o professor Samuel, falou uma coisa muito interessante sobre atividade física regular. Eu acho muito importante a gente, nesses tempos de hoje, falar sobre cuidados da saúde vascular. Às vezes a gente fica falando de droga daqui, droga dali, droga de lá, e se esquece que uma boa panturrilha para ejetar o sangue de volta ao coração é um excelente método de prevenção. E quando o senhor
Bruno,
falou...
Ótimo! Aí eu posto que tem que treinar panturrilha e os caras ficam fazendo bullying em mim. Ótimo, Bruno. É isso aí. Vamos perder
quando o professor Samuel,
vai criticar.
Professor Samuel falou que a gente está vivendo mais, mas também está tendo mais embolia pulmonar, é por causa de sarcopenia. Nós perdemos massa muscular ao longo dos anos. Então, a partir dos 50 anos, a gente tem que trabalhar exercício resistido, força muscular. Se a gente não fizer isso, a gente vai ter dor para tudo quanto é lugar, embolia e TVP. Então, assim, nada contra a medicação, que viva a medicação, mas a gente tem que pensar nas atitudes para cuidar bem da nossa saúde vascular. Era esse detalhe que eu gostaria de falar. Obrigado.
100% do meu apoio, Bruno. Total.
Eu gostaria de deixar um convite para que todos visitem as nossas redes sociais do Congresso, tá? 44º Congresso Brasileiro de Angiologia e Cirurgia Vascular. Nós vamos atualizar semanalmente, né, os nossos convidados através das redes sociais. Muito obrigado a todos. Obrigado, Fabrício. Obrigado, Eduardo. Obrigado, Bruno. Obrigado, Léo. E a todos que participaram no Brasil e na América Latina. Professor, thank you very much for your kind attendance.